Good afternoon. I'm Alan Unell, and this series of videos is called Healthcare Reform Advocacy. We address problems in the healthcare system and have actions that we can all take to make healthcare better for all of us. We have a number of topics for today. First, let's go over private equity and healthcare. In the past, we've had discussions in the Healthcare Advocacy Newsletter about how private equity and healthcare really don't work well together. Investors make money, patients suffer with lower quality care. Not a good combination. One of our readers, Judy, pointed out to me a webinar that was hosted by Physicians for a National Health Plan that discusses the problem in detail. The title was How Private Equity Makes Us Sicker. In the Healthcare Advocacy Newsletter, which is the text for this video, you'll find a link to the webinar as well as a link to the slide package. I heartily recommend it. When private equity owners take hold of medical facilities, their goal is to make money. I have a friend, Barbara, who's a physician, who likes to point out that private equity firms have not taken an oath to do no harm. That's the Hippocratic Oath. They're there to make money. Now, in short, here's how it works. The private equity group creates an investment fund and promises investors large returns, typically substantially better than the stock market. Otherwise, why would you bother giving them the money? To provide these outsized returns, they buy up healthcare providers and extract wealth from them. They do not do this to provide healthcare services. The healthcare portion is merely a means to extract money. Here are some of the techniques they use. They load up the facility with debt. They reduce the services offered because services that are not providing lots of income, you don't need to do. They try to monopolize a market when they can and then increase the prices. We saw that just the other day with a group called ASAP, which is an anesthesia conglomerate. The Federal Trade Commission is suing them just for that, for antitrust. They sell or lease back properties at high rates. We saw this done a few months ago in the southern United States, where a hospital was taken over by a private equity group, and they created a whole bunch of sub-companies, all vertically integrated. One of the sub-companies was a real estate company that actually owned the physical hospital and leased it back to the conglomerate at really high lease rates. Vertical integration, but it's all funneling into the same company. They force cost-cutting measures in order to service the debt. They do short staffing, fewer people, and reduce supplies. Because remember, the fewer expenses they have, the more money they'll make. They then pay extra high dividends to the investors and keep the facility providing as much as possible to the investors as quickly as possible. And the goal is generally to get out of the market in 3 to 5 years. And if it's profitable, sell it off to another private equity firm at a huge profit. Okay, is this really done? The answer is yes. Here's an example. In the nursing home industry, we have found that mortality rates in private equity-owned nursing homes are 10% higher than the overall average. Medicare billing is 11% higher in private equity nursing homes. Frontline nurses spend fewer hours with patients. So let's recap. They bill more, they cut expenses, they make more money, and more patients drop dead. What a concept. The latest tactic that I read about involved urging emergency room physicians to overtest and overtreat patients, prioritizing the priciest services. A recent study concluded that high-intensity billing for expensive emergency services has gone up 400% in the past 15 years. What a moneymaker. I'll tell you, one of the things we discovered in at least one hospital chain was an internal memo to the emergency room staff to make sure that if a pregnant person shows up and they're just there for a normal delivery, make sure you bill them for the emergency room service, because there's no sense leaving those extra thousands of dollars on the table. Charming. Another technique is to use physician assistants or nurse practitioners instead of doctors. You can charge about 75% of what a doctor bills out for a physician assistant, and you can pay the physician assistant far less than what a doctor makes. Now, this works in some nominal primary situations, but it is likely not ideal for the patient who's in a complicated setting or presents with complicated situations like an ER. I got to tell you, personal experience here, I found it to be a tremendous waste of time. I was assigned a physician assistant or a nurse practitioner, I don't remember which, by my local clinic up here in the Pacific Northwest. And this woman had an incredibly hard time reading an EKG over and over and over. I had multiple office visits just to try and get cleared so I could get surgery. When the cardiologist finally took a look, he said, "Oh, this is beyond her ability. It's just an artifact." So sometimes the physician is the best one because they've got the experience. Okay, so now that we've seen all of this, it is no wonder we spend 50% more than our peer industrialized countries for healthcare. We have a system that's being squeezed to generate as much money as possible and increasing the prices along the way. The system is rigged to get every dime out of it from patients, from insurance companies, and the government. Hold that thought. We're going to be coming back to this on a different day. I want to talk briefly about cancer research. This is a happier story. I don't know if you remember, but the Biden administration took on a goal of cutting cancer deaths in half. That's a pretty noble goal. There is a new biomedical research agency that they've established for health. It's called the Advanced Research Projects Agency for Health, ARPA-H. And this past Tuesday, they announced that their first two hubs are going to be located in Dallas and Boston. The agency is going to use a hub and spoke model for research rather than centering all their activity in one city. Part of the agency's charter was that it would not be located in Washington, D.C. Actually, that's a pretty good idea because there are experts all over the country, and it turns out that Boston and Dallas are both incredibly high medical research areas. So that's a great idea. I'm glad to hear that. And of course, there are going to be a lot of STEM jobs in those districts to go with. Let's talk for a moment about telehealth. This is also a good news, bad news kind of a story, but it's to provide information to you on how the world of healthcare is changing. According to Axios, Costco is joining big retailers' push into primary care by offering members, get this, $29 telehealth visits and lab testing and virtual mental health services. The big picture, it's part of a broad effort to use digital tools to create more customizable patient experiences. And it's also drawn in the likes of Amazon and Walmart and CVS, and I couldn't believe this, Dollar General. Retailers believe they're better positioned to tap into consumers' tastes and frustrations with the traditional health system. So what's happening? Costco is teaming up with the online platform Sesame to offer these $29 virtual primary care visits, no wait times. You just get it the same day. A standard lab panel and consult will cost $72, and a virtual therapy visit, $79. Costco members can start booking services on next Monday. In every state, Sesame operates outside of insurance networks, catering to people with high deductible plans who pay out of pocket for basic care. And of course, it caters to those without health insurance at all. Bottom line, it's probably suitable if you have no insurance or a really high deductible copay plan. By the way, $29 is the value of the primary care televisit. And keep in mind, they all make money on that. Okay, yesterday's stories had to do with nursing and healthcare and the problems there. I received a number of messages from readers, and I want to share some of them with you. Thanks to Irene for sharing this message from the Annals of Medicine and Surgery, June 2022. Another reason that nurses leave the business is due to assaults on the job. Although violence in the workplace affects almost all sectors and groups of workers, it's apparent that violence in healthcare settings provides a significant risk to public health and an occupational health issue of growing concern. The healthcare and social service industries have the greatest rates of workplace violence, with workers in these industries being 5 times more likely to be injured than other workers. In addition, workplace violence in the health sector is estimated to account for 1/4 of all workplace violence. Workplace violence is constantly on the rise in the health industry due to rising workloads, demanding work pressures, excessive work stress, deteriorating interpersonal relationships, social uncertainty, and economic restraints. And a friend of mine points out, in addition, lack of trust in the existing system makes people way more anxious in an emergency health situation. Now, another contributing situation is that patients and their families often feel they have completely lost control of their bodies and the situation. Remember, staff is overbooked, they cannot respond as quickly to requests for help as expected, and people, when frustrated, act out and hurt others. It's never an excuse, just an observation from an insider to me. I also want to present an update on the nursing infrastructure. This is thanks to Karen, who's a nursing professor and a reader of Healthcare Advocacy. And she observed that the nursing diploma programs are being phased out. As the complexity of patient care increases, it requires a much more extensive grounding in the sciences. There are fewer than 100 Bachelor of Science degree programs in nursing left in the United States. And sadly, most hiring agencies want to hire someone who has a commitment to complete a Bachelor of Science in nursing within a certain period of time. A BS in nursing is considered the ideal standard for nursing education and has been encouraged for decades, but sadly, there are not enough places or seats in classes for all the people that want that training. Okay, here's an action we can all take. Let's remind our senators to co-sponsor Senate Bill 2840, the Bipartisan Primary Care and Health Workforce Act. It provides for an additional training for nurses to get 60,000 of them in place in the next few years. And part of that funding that they're going to provide is extra money to colleges and universities to make sure that there are enough places for the people who want to be nurses. I'm going to put a link in the description section so you can find your contact information for your senators there, either email or phone number. All of the links are going to be in the Healthcare Advocacy Newsletter. I'll give you a link to that in the description section. Like, share, recommend it to others, put in comments in the comment field, or you can send them to me at healthcareadvocacy1@gmail.com. Have a great day. We'll talk to you soon.